analysis. I do.
Yes. So I won't steal your thunder.
Although,
Yes.
I'm not going to tell you about it,
Okay. Well, then
which you didn't know.
That's okay. That's okay. I just noticed that on your CD it was your thesis.
Yes, yes.
And then all of those author articles
Yes.
are about in that clinical area, which I think is really interesting for a biostatistician, who we normally see kind of working clinically agnostic and then more as a methodologist, which it looks like you're going to talk about.
I take full responsibility for changing what I was going to talk about really at the last minute. I love anaphylaxis. I've done a lot of work in it, but I've also worked in a lot of different content areas. And as I was going through my talk, I was realizing that that was presenting to you a very specific content area and the methodologic challenges and approaches to that particular content area, but wasn't really getting at sort of the breadth of work that I think an epidemiologist, biostatistician does. And so then I was thinking, well, I've done some really cool stuff related to elder abuse. I've collaborated with Jonathan and done some really interesting analyses in the bronchiolitis sphere, and we're doing a lot of work in telemedicine currently at Weill Cornell. And so those are all interesting in their own right, but there wasn't really a theme until it occurred to me as I was reflecting back on my conversation with Alina that really the theme was collaboration. And I was the methodologist that was collaborating in my own content area that I loved and adored, as well as in all of these other content areas. And so at the last minute, I decided that I was going to talk to you about working with your methodologist, since I think you guys are interested in boosting the methodology and the biostatistics within the group. So this could either be a raging success or it could be a complete flop. If I get fired, it's all on me. Dr. Landrigan and Dr. Chin knew nothing about it until just this moment. Okay, so who is your methodologist? I think there are a number of us who have advanced training in a specific discipline, but probably cross a few disciplines. Mike and I both trained at Harvard School of Public Health down the road, and as doctoral candidates in epidemiology, one of your required minors is in biostatistics. That suited me quite well because after I did my master's degree, I worked as a master's level analyst for a number of years before going back to school. And so I probably took a career trajectory perhaps a little different than most epidemiologists that pursue maybe a particular area of interest and do more independent work. And I was really in sort of the applied biostatistics epidemiology sphere. And so your methodologist may be an epidemiologist or a biostatistician or a psychometrician or a data scientist or something similar. But I believe, this is my opinion, so open to any input, but I believe that this is the person who will collaborate with you on your ideas from the beginning to the end, not just the consult who comes in at the end to crunch some numbers. So I think this is the person that helps formulate your questions and hypotheses. And there are things that go into this beyond thinking, I have a good idea and I want to see if X is related to Y. You need to think about what your outcomes are, how you're going to measure them, what your exposures are, if there are any, and how you're going to measure those. And that plays into the questions you can ask and the hypotheses that you can put forward. Identifying the appropriate study design. What is the best way to design the study so that you can collect data that's meaningful to answer this question and address these hypotheses? Writing the statistical analysis plan. And so this is probably the key area I think that most people think about. But if these aren't set up well, no matter how well and technically savvy this is written, it's only going to get you so far, and this may or may not produce meaningful results. So I think it should be a collaboration throughout. And then interpreting and presenting data. I don't think it's enough to just, here's your table one, and here's your your table 2 and here's a fancy figure and off you go. I really think that this is a collaborative, iterative process. And so I wanted to describe to you a little bit my distinction for this methodologist between someone who is a collaborator who's really integral to the work that you're doing and someone who's a consultant. And you'll note that I fall more on the preference of the collaborator side. There is still a role, I think, for a consultant side. So I think your collaborator is an active co-investigator. I think it's someone who starts to get down into the weeds of the content area with you so that they really understand what's going on and what it is that you're trying to do. They're brought in early. And as I mentioned on the previous slide, they're really helping to develop aims to identify the appropriate study design, to get that analytic plan ready with the appropriate sample size and power analyses, but those are also contingent on the study design, the data that you think will be collected or the data that are available and what those data look like. They're continually involved in your project from the beginning to the end. So if there are hiccups in recruitment and things need to be readdressed, having your methodologist be an integral part of your study team allows that stuff to evolve as these things are happening in real time. And of course, they conduct and oversee statistical analysis plans and then also contribute to the interpretation and presentation of your data. And I see the consultant as perhaps a little bit more removed. Maybe they're brought in late because the grant wasn't funded or the reviewers had comments from the journal, or you've written everything and realize you need that dreaded sample size and power analysis. Or maybe you've collected data for a study that maybe could have been designed better, or maybe was designed perfectly well and the data were collected perfectly well, but now you have all of this data and one is not quite sure what to do with it. So while I think there are merits to both of these, in my conversations with Alina, I was thinking that you guys might be leaning a little bit more toward this side, and I think this side is more fun to work in for the bulk of someone's time who is on the methodologist side. So what does the process for this look like? First, the investigator has a brilliant idea. And then they reach out to the methodologist when? Early. Everyone gets together and collaborates, and they produce something that is useful and valuable and contributes to clinical care, contributes to public health, and moves the field forward. And so the key to all of this, I think, is open communication, and probably patients should be there as well. And I think that is important on both sides. Okay, so keeping with the theme of starting communication early and often, I think a wise person once said, to call the statistician after the experiment is done may be no more than asking them to perform a post-mortem examination. They may be able to say what the experiment died of. And I'll cross it out and say methodologist. So what can we do early when we get together? What should be the methodologist's expectation? What should be the investigator's expectation? So I think the investigator should be prepared to share a lot of information. They should come with relevant background literature, not only to support the question that they're developing, but also to help educate their methodologist in their content area. They should bring any measurement tools that exist, or bring any information they have about what they would like to measure for which tools don't exist. That may need to be part of the study. I think they should bring with them to share any data collection instruments that currently exist. Bring with them a list of any existing data sources that may either be used or may be used to structure the data that will be collected for the study. And I think the investigators should come with their expectations for what this relationship is going to look like. And I would say that initially, things should be communicated in simple terms. So your methodologist likely does not have clinical training. They may have worked in a clinical environment for a long time, but you're really the clinical expert, and so helping them to understand what you're doing is important. And so what should you expect from this mythical methodologist person? Well, one is certainly some design expertise, assistance in helping to choose the most efficient study design. You know, there are some there's some, you know, good old standbys that we go to, but there may be a better way to do things. So being able to talk about what's been done in your field and what you think you're interested in doing may help your methodologist to really flesh this out. You should expect that your methodologist will consider all of the aims of your study, not just the primary aim. You should expect that they will help you through the sample size considerations and to think about what they need to be able to assist you with that. And I think that this shouldn't be overlooked. Thinking about your interim monitoring plan. And that may look one way for clinical trials where data needs to be monitored, but I think even for observational studies, we should be monitoring data as it's coming in to make sure we are collecting things the way we think we're collecting them and that we're receiving high quality data to work with. I think you should also expect that your methodologist will help you identify what your endpoints are. Are they subjective? Are they objective? And how does that play into how we can analyze them? Are there measurement issues that we need to think about? Not only how we will measure things, but what measurement error there might be and how we're going to manage that. Are there multiple endpoints that we should be considering? And this can be both primary and secondary aims. This can be subgroup analyses, and as long as we are clear and transparent about what we're doing, these may be post-hoc analyses that come up as we're going through the work that we're doing. I think that this is the key of what most people are thinking about when they think about working with their methodologist or their statistician. And so I think that this is also critically important. What will the statistical methods be for all of the aims of the study? How are we going to account for our type 1 and type 2 error? How are we going to account for our measurement error? What do we need to do when we think about confounding and bias? And are we able to assess missing data, not only from an analytic perspective, but are we able to think about where some of the hurdles might be early on so that we might be able to avoid some of that? And again, I think you should expect that all of this is communicated in simple terms, right? Maybe at the beginning, the clinician investigator and the methodologist are speaking different languages, but I think if they try to communicate simply and are mutually respectful, I think they can find a common ground where they're really understanding what each other is saying. Okay, and so with that, now I think it's sort of the fun part, coming together and working together and getting the data out. So how can this collaboration be beneficial to the investigator? I think it can be helpful in myriad ways across the spectrum of the study or across the spectrum of the research realm. And I think it can start with helping with your question. So there's a bad question or maybe not such a great question. It's a little too vague. It's a little too generic. Is radiation therapy helpful or harmful? And maybe in discussion with your methodologist, you start to get to a question that has a clear exposure, a clear outcome, and is measurable and testable. Your methodologist can help with choosing your study design. Is the best approach an observational study? Have we reached a spot where we're ready for interventional studies? Discussing the different study design options. All study designs have inherent strengths and limitations, and discussing them up front and figuring out which the best one is, I think is important, not only for the design of the study, but important when we think about being able to analyze and interpret the data. And also the need to consider special study designs, right? So probably everyone learns the basics at some point, but when do we need to start thinking about some different study designs? And I neglected to say when I started that one of the things that I was thinking about when I reflected back on my conversation with Alina and completely switched gears for today was that probably a lot of what I'm saying is old news to most of the people in this room. Many of you are already well on your way to successful research careers, but as I thought more about your cohort advancing and bringing in the more junior folks, this seemed like something that was important for them and important for thinking about building things out. And then describing data structure. This is important for thinking about how you're going to collect data, important for thinking about how data are going to be analyzed and how they're going to be presented. So what are your outcomes and your exposures looking like? What are your covariates looking like? Have you identified all of your confounders? Have we done a deep enough dive in the literature to make sure that we're considering everything we can consider? And what are our sources of data and what are the strengths and limitations of getting them? So if we're getting information directly from subjects, that may be helpful. Of course, that may be subject to errors in recall, as well as biases. The EMR is, of course, a wealth of information, not specifically designed for research purposes, and so it also has its inherent limitations. Direct collection of data of biospecimens and such are great, but that can also be expensive. So how do we strike the balance here? And then defining your sample. So how you define and select your sample can influence the inferences you can make about your study. So stepping back and discussing with your methodologist and really thinking through what's the population that's being studied, how can we sample from that population, and how can we then make inferences back to that population. And so just very quickly through a couple of approaches, very simple random sampling where everyone has an opportunity and an equal opportunity to be selected. Simple and straightforward, but not always possible. So what could we do if this wasn't going to work for us? If this was going to end up giving us a biased sample, which would show us some results that weren't really truly reflective of our population? Well, we might want to consider some stratified random sampling where we identify some more homogeneous groups within our larger population and start to sample from these groups. So this can help us with the precision of the analyses that we're doing as well as the representation of the results that we're presenting. And then maybe we're unfunded, or maybe we really need to think about the costs of the study and ways that we can improve efficiency, and so maybe we need to think about doing some cluster sampling. So thinking a little bit more broadly about how we're going to identify the study sample that we're going to pull in. Your methodologist can help you select the best randomization approach. If we've identified an interventional study that's going to allow us to randomize our samples, do we want to think about simple randomization? It's easy to employ, but it has its own limitations. We want to make sure that our groups are balanced at the end of the study. Perhaps we think about blocked randomization, which on average gives us pretty well-balanced groups. Or maybe we need to start thinking about some stratified randomization. And this is important not only for designing and implementing the study, but also thinking about how we're going to analyze the data that we have. So having input on the front end helps not only with conducting the study, but also with analyzing the study appropriately. And then determining sample size, which is something that really the methodologist hears about quite a bit. And here I would put forth that this is not a one-size-fits-all request. And it's important that the investigators remember that it's influenced by a number of things. That includes the study design, the outcomes that will be evaluated, as well as the analysis plan that's put forward. And there are some times that the sample size is fixed. We have the sample that we have, and so we need to think about backing in to the power that we have to detect differences. And I think perhaps just a reminder that the sample size and power analyses are something that tend to get thrown in at the last minute. We need to put them in, they're required, the grant's not going to do well, but there are some really important reasons to do them and do them well, and not just do them overnight quickly so that we have our sentences in a little table in the grant application. Because at the end of the day, we get results, and if we don't show an effect, are we not showing an effect because there really was no effect? Or does it turn out that our sample size really was too small to be able to detect what we saw? Or did our intervention really work? The difference that we observed, perhaps it was statistically significant, but was it clinically meaningful? So also thinking about striking that balance between statistical significance and clinical significance. And I think getting to this is possible, certainly desirable, and I think it can be done in a meaningful way if we start these conversations early. So more sample size and power, and thinking about collaboration and communication and being effective together. So here I have been on the receiving end of requests for sample size analyses, the night before or the day before with no information whatsoever, a little bit more analogous to, I'm interested in whether radiation therapy is helpful or not. So thinking about open lines of communication, there is some information that's required from the investigator to be able to help and facilitate with this. And one is, how much better do we expect one group to do than the other? Is there a difference that we're expecting to see? How much variability are there in the measurements that we expect to see? Are we going to have a mean with a very tight standard deviation, or are we going to have something that's going to have a really wide variance? And these are critical things when you're evaluating your sample size analysis. And then what is clinically relevant? What is meaningful? We may be able to detect a 1 point difference in blood pressure, but does that really mean anything? So really striking that balance. And so just the reminder that the investigator needs to define these parameters, needs to help the methodologist to identify these parameters so that useful information can be provided. Though if there's pilot data, we can probably figure this out with some internal data, but I think this tends to be less frequent, and the top part tends to be more frequent. So again, just keeping things in mind and thinking about communication. And your sample size and power analyses will look different depending on the type of work you're interested in doing. So for descriptive studies, we're really thinking about the precision of the estimate, or the precision of the item that we're trying to measure. And so a really good question comes in as the investigator wants to plan to prospectively collect data on a certain number of consecutive patients. They expect that about 15% of the patients will develop delirium while they're in the ICU based on prior literature. And the methodologist says, great, I can work with that. With your 200 patients in your sample, our 95% confidence interval to identify the true proportion of delirium can be constructed within about 6% if the sample proportion is 20%. So we have enough information to get something meaningful out of the back end. And likewise, if we're interested in comparisons, we need to think about what the difference is that we expect we're going to see between the groups, so that we can evaluate our sample size and power. So here, our investigator comes with a well-structured ask. I think that if I retrospectively collect data on about 500 subjects, I think about 70% will have polysensitization polysensitization allergies, and 30% will have monosensitization allergies. And I think a difference of about 13% is the minimally clinically meaningful difference. And so the methodologist is able to respond and say, okay, you will have 80% power to detect this 13% difference between the two groups if your proportions are at 70% and 57% respectively. So useful information in, useful information out. Your methodologist or statistician also helps with data management, either directly or through helping to supervise a team. And some of these are pretty simple and perhaps pretty silly, but I think they're important. Clearly identifying your column names or your variable names. Column AE in the Excel sheet is not helpful because it's not always going to be column AE. Developing a data dictionary. What are the variables of interest? What are the variables that are included? What are their column names or their variable names? How are they defined? If we have continuous data, what's the range that we should expect? What are the units of measurement? What are the definitions of the levels for the categorical variables? And thinking about this ahead of time, I think prevents a lot of heartache on the back end. If you have some measurements of temperature in Celsius and some measures in Fahrenheit, it can be challenging to know which is which. And if no one's paying attention to the data, could even report out something that slips through the cracks and is just inherently wrong. So thinking about this ahead of time makes, again, for a more robust study and for a smoother study process. Your methodologist can also discuss with you and help you to set up your data set. So avoiding things like, well, the color coding didn't really show up here, but avoiding things such as color coding that can't really be analyzed in statistical packages, or setting up data structure in such a way that it's very difficult to impossible to analyze, that requires the data to be entirely restructured, which then could introduce errors in its own right. Thinking about your study design and your data collection and the structure of your data with your methodologist early on also helps to avoid ambiguity. So what will the data formats be? All of these dates are for the exact same day, but if they're recorded differently, they can be interpreted by different statistical packages in different ways, and it can be difficult to manage. So thinking about how that's going to be done on the front end is important. Also thinking about avoiding free text responses when possible. It's not always possible, but blood type is certainly something that could be categorized ahead of time. We also want to think about avoiding ambiguity for data sets. And some of this I described on the previous slide, but variables should have their own columns. Observations should have their own rows, and values should have their own cells. And so I like things tidy, so I like to think about keeping data tidy. So this and that side are presenting the same data, but this is not useful. This gives us a lot of information, but it gives us information that we can't analyze. We need to restructure it, and it needs to be restructured on the manual side, which can prevent errors. So we've got our individual variables, we have the information in individual cells, we have a plan for managing missing data rather than question marks, and we can work with that very easily and very quickly, and we can identify errors very easily and very quickly. And then analyzing data. And I think this does need to be thought about ahead of time and not just at the end once the data have been collected. If we have interventional studies, RCTs, we need to think about whether we're doing intention to treat analyses as treated analyses for protocol analyses, and these really need to be protocolized ahead of time. These shouldn't be things that are thought of on the fly at the end of the study because we did or didn't get the result we wanted. And all of them have inherent strengths and limitations. I would argue that none of them are inherently wrong as long as they've been well thought about ahead of time and implemented appropriately. Do we have observational studies where we need to think about some propensity score matching to be able to evaluate the effectiveness of interventions? Have we thought about our confounding adjustment and how we should be doing that? Should we be simply stratifying data? What types of models do we need? Have we met our statistical assumptions for the data? If everyone already knows the data structure and the way the data will be handled, this is easy to address. If we're trying to learn it on the fly, we're more prone to error. And then are there other data concerns that need to be thought about and need to be addressed? Again, if we've been having this conversation over a period of time and we're thinking about it as the data are coming in, we're more likely to be able to address those concerns and avoid introducing bias into the studies. And so a couple of designs or a couple of methodologic things that I think are important to think about that are relevant to assumptions and whether particular data concerns are being addressed. One would be thinking about longitudinal data. So a very standard assumption from many statistical tests is that the observations that you're analyzing are independent. They're not related to each other. But for longitudinal data, we have many observations for individual subjects over time. And so this needs to be planned for, and this needs to be analyzed appropriately. And certainly this approach has benefits. We can measure changes in individuals over time. We're able to start to separate out different time effects. We can control for cohorting effects if there's a long recruitment period. But doing longitudinal data analysis requires that we think about special considerations for these types of data. The data, as I mentioned, are correlated within subjects. Do we need to think about time varying covariates? Does that need to be incorporated into the analysis? And longitudinal studies also have a high possibility of having attrition or missing data. And so we need to think about that. And so thinking about the missing data, losses to data can not only damage the internal validity of the study, but they can cause major damage to studies and prevent us really from being able to draw conclusions. So we want to think about the kinds of missing data that we might have ahead of time to see if we can head it off at the pass. If we find that we're ending up with a large amount of missing data, thinking about how we can assess what type of missing data we might have and how we might be able to use it. So if we have data, if we have a high amount of missing data or a missing amount of data that we can't ignore, should we think about incorporating survival analysis as one approach? Are we able to carry the last observation forward? Should we be thinking about multiple imputation? And of course, each of these come with their own strengths and limitations as well. So we should be thinking about these things carefully and over the course of the study and trying to anticipate them as well as reacting if we find that there's a problem. Something that I also think is very important that an investigator should think about and should be discussing with their methodologist is human subjects protection. And I think that this plays into a lot of the things that we've already discussed. I think the sample size is important not only to be able to determine whether or not what you did was statistically significant or clinically significant, but we do ask something from our subjects when they participate in our studies. And that may be asking them to take a drug that we're trying to develop, which has known and unknown side effects. That may be asking them to allow us to use our data that may have an effect on their confidentiality or their anonymity. So I would say that having an appropriate sample size not only helps the study and the integrity of the study, but it also protects the subjects that participate in our study by not recruiting too many people and exposing too many people to risks that they wouldn't otherwise be exposed to if we didn't really need them in the study to begin with. I think that it also allows us to think about what some of our interim analyses and stopping rules will be, so that if we are showing early on that there is benefit or harm or futility, we can stop studies in a meaningful and thoughtful way. And I would also put forth that it's important to think about HIPAA compliance and to think about protecting data. Much of that I've already described, but I will just say that your methodologist should know what the HIPAA identifiers are, should be able to have conversations about what data we need to collect, when we can remove data from data sets, what links we can make between different files so that we're sure that identifiers are protected, and then how we can manage data and how we can store it in a way that protects the subject. So should we be using REDCap versus Excel? Yes, we should be using REDCap versus Excel. Should we be storing our data on secure servers or on our personal laptops? Some of this really is common sense, but it never hurts for all of us to be reminded about it. So having these types of conversations, I think, is important. I think that it is also important to think about realistic deadlines from both perspectives. I think it's sometimes necessary, but not reasonable all the time for someone to say, I need something done tomorrow. I also don't think it's reasonable for your methodologist to say, it's September, I can get that to you in February, right? There's some give and take. So again, realistic deadlines for everything that we're doing, ample lead time, and open communication. And so I just gave you my punchline already, but it's really important to me, so I'm going to give it to you again. I think if we follow some of these steps, I think that the investigator and the methodologist can really collaborate effectively to do meaningful work that is valuable to the patients that we're treating, to the public, and I think it can also be a lot of fun. And I think with that, I thank you all for your time. If you want to hear about anaphylaxis, I'm free for the next hour. I have that presentation ready as well, and I'm happy to take your
We do have a few minutes for questions.
Okay, let's do it.
I'll start with some. It's so helpful to see how you envision working with the more junior members of our division. But I wanted to hear a little bit more about what you've more recently added to your methodological arsenal, and a little bit more about what intrigues you personally as an epidemiologist.
Okay.
And so would you like to take a moment to talk about that?
Sure. Some of the work that I have found really interesting and engaging recently has been in an area that is far removed from what any of you are doing, but goes back to sort of I've gotten to dabble in lots of different content area. And it's probably more on the developing the study side rather than the analytics side, though it has important implications for that, and that's been in the area of elder abuse. I have a junior moving to mid-career colleague and mentee who is very interested in identification of elder abuse in the clinical setting. And as we were designing some of his studies, it became very clear that we were missing a taxonomy for identifying injury patterns in older adults. And so that led to drafting a protocol for describing injury patterns in older adults, and it really was a multidisciplinary interdisciplinary effort, including many, many meetings with an anatomist and with an artist who was able to draw renderings to be able to identify, I think, 126 precise locations for injuries in older adults that would need to be identified to be able to see if there were differences in the older adult sphere. Many older adults who are victims of abuse come in and say they fell. That's sort of the common complaint. And so what we were interested in doing was seeing, can we identify differences in injury patterns from fallers and those who have been abused. So that was great, and we got that out there, and we okay, now we're ready, let's go. And then we realized that the cases, and this is part of this is an entirely other methodologic problem. The cases that we were able to use that we considered highly adjudicated cases were those that were prosecuted by the DA. And so we didn't have direct access to those individuals at the time of the abuse. All we had were photographs that were taken for forensic purposes. And so we thought, well, if we're going to compare those to fallers, we should probably be comparing photographs as well, rather than the orbital injury right in front of us to the photograph that was taken. And then we realized, well, if we're going to take pictures, there's nothing we can do about the way the forensic pictures were taken, but we should at least be collecting our photographs in a systematic way. So we developed a photography protocol that could be carried out by researchers who were not trained photographers. And some of it was super simple with a ruler and some colored dots to evaluate, stages of bruising, but some of it was also to measure sizes of injuries and to figure out how the photograph should be taken from far away and close up and with and without the ruler, as well as protecting the subject's privacy and their rights. So who should be in the room and how that should be done. And so while those are more on the protocol development side, it was super fun. It was not something that I ever thought I would be doing. It was critically important to the work that we were doing, and it allowed us to collect meaningful data that we were able to analyze. And so that was something that I was sort of proud to be a part of and really enjoyed.
Yeah, there are a lot of analogies between caring for children and caring for elders.
Yes.
Both dependents.
Yes.
And
yes.
Jay and his wife, who's a geriatrician.
When I was meeting with them, they were talking about that.
Yeah, exactly. They were together. We also really had a really great Math and Even lecture. That's our child abuse lecture each year. And it was those body diagrams, like a histogram of where abuse patterns occur, so we can tell the difference between unintentional injury.
I was thinking a little bit about, a lot of your discussion was focused on either simple observational designs or kind of a typical randomized controlled trial type of a thing, where you're enrolling patients one by one and figuring out sort of how to deal with that, both from the study design and analytics standpoint. A lot of us in the room do kind of systemic interventions, where potentially you're going out into the community and trying to introduce something as in a clinic. Or, my work is similar in the inpatient setting, where you're changing the way that some unit operates. So I was wondering if you could talk a little bit about just the methodologic challenges of doing that kind of work, and how you think about analysis.
So in that setting, one of the first things that comes to mind is thinking about how that intervention can be replicated, the fidelity can be maintained, and it can be systematically implemented in places that may or may not be similar, and thinking about how the settings differ and how the differences in the settings affects the intervention that you're implementing. And so that's sort of high level, but I think we need to think not just about, okay, here's the intervention and did it make a difference, but maybe it makes a difference in a different way, maybe it needs to be thought of in a different way depending on the setting.
Yeah, and I think that, there's always this challenge in that work of thinking about, just as you're saying, the fidelity to the intervention, but then there's sort of the implementation science
Yes.
pieces of how does context make that vary. And
Yes.
how do you put those things together when you're rolling something out and then ultimately trying to analyze the results of a complex intervention that's happening in, let's say, many different clinic environments.
Have you had any experience kind of jumps off what Chris was talking about in projects that are kind of on borderline between quality research, QI research?
Yes.
What are the challenges there?
Some of that is great, and some of that makes me want to bang my head into the podium. And I think that is an area that I have a lot of experience in, and I have to readily admit that some of those experiences have been wonderful and successful, and some haven't been so successful. I think it is. I think if anywhere, that is a place where it's very important to start these conversations early, because I think a lot of these quality improvement interventions, and Jonathan was sort of alluding to this when we were meeting, they take a lot of work to do, and so we should be thoughtful about how they're going to be evaluated and not just sort of doing them in a vacuum per se, and then at the end of it saying, oh, we should study that. And so I think that there's a balance to strike there, and I think there's a little bit of a gray area, and so I often wonder if perhaps we could involve our quality improvement folks in some discussions about research. It might just help sort of the brain to think a little bit more along the lines of the scientific method, and how we might better take advantage of those opportunities. Yes, I spent a lot of time in
Is that
this
what makes
space.
you want to bang your head?
Hmm?
Is that what makes you want to bang your head into the most people coming afterwards?
Yes, yes, yes. Yeah.
Do you have an example of one that worked well? That flavor of work?
Yes, so we are, we're working on it ended up being a very simple pre-post because it was either all or nothing when it was rolled out, but one of my colleagues was interested in trying to make the ED discharge process more tech savvy, more friendly, instead of reams of paper that go to the patient that they lose, and they're not, complying with their discharge instructions, they're not following up for care, they're not taking their medications. They wanted to test whether a simple text message with a link to the discharge instructions might be better for patients. So we sat down ahead of time while he was thinking what this might look like, and we were talking with the IT folks about how this could be built out. We were able to sit down and think about what data will we have access to on sort of the aggregate scale, because IT had let us know this was something that could be on or off. There was no way to randomize the rollout of this for a number of reasons. And so we were able to sit down and think about what would be the outcomes that would be of interest to measure, what would be the outcomes that would be attainable in a way that was consistent across both periods, how long would we be studying this so that we could think about whether or not there were temporal changes on either side that were unrelated to the intervention, and also allowed us to think about what data that we might need to collect on patients, and how we might be able to distinguish between those who got the discharge text and those who were in the discharge text cohort but somehow still ended up with paper, and how we might think about that. And so that conversation started really early, and so it ended up being a very easy project to do, and it ended up being really fun to work on. Yeah.
Something that comes up a lot in my work, and I think it comes up in some of the Gen Peds work too, is working with large administrative databases or large surveys, maybe from CDC
Mhm.
or
Mhm.
some other agency or maybe a private insurance company
Mhm.
where we don't have any control over a lot of the elements you
Yes.
described. We have nothing to say
Yep.
about study design,
Yep.
data collection, the structure of the data. How's describe maybe your approach if you've worked with one of those
Mhm.
studies before, how you thought about data analysis and that sort of study, and if you have an example in mind, maybe tell us a little bit about how.
Yes, I have worked with many of those large data sets. I have not worked with claims data. That's not in my arsenal. Certainly willing to learn, but for the sort of the patient level data that's available, my approach tends to be to almost take a look at the data from a data cleaning perspective, to not only understand the materials that are provided by the source that collects the data, but also to go through the data myself to understand where the missing data are, where the values are that maybe don't quite make sense, and to start to think about a broad analytic plan from that perspective.
Can you think of a sort of an example of a study?
Oh yeah, actually in some of the anaphylaxis work we've done, we worked a lot with the National Hospital Ambulatory Medical Care Survey, looking at, this wasn't a plant, but it feels like that. But we were working with these data to look to see if we could identify trends over time in ED visits for acute allergic reactions and anaphylaxis. And as we're looking at this, ICD-9 codes are also changing, and there are differences in the way the codes are being used. And so it was something that we had to be very mindful of. And I think one of the biggest things I've learned from working with a lot of those data is to be careful not to overinterpret the results that you have.
One question?
Yes, can you speak to the youngest youth faculty, and so some of your trainees in the room, but some of your experience with trainees, and I think trainees here are quite outstanding in many ways, and not all have had research training, and so I think trying to sort of get them up to speed with research skills and analytics when that may not be their strength. Sort of efficiency, because they have a year or two of research time versus, or maybe even a month of residency time to research versus like.
So I guess one of the things that I feel pretty passionate about is that research is a team sport. And so I think understanding the fundamentals and being able to communicate, and so that means your methodologist needs to learn about the disease area that you're working in, and then you need to know a little bit about what a continuous variable is and when you might use a t-test, but perhaps it's not useful for a junior investigator to try to learn R or STATA if that's not the direction that they think their career is going. So I would say my theme is starting these conversations early, but I think not only starting the conversations early, but building your team early so that you're not spending a lot of time. If that is something that you want to do, you should absolutely build your statistical chops and your coding. But if that's not the trajectory of your career, I think building that team moves things forward more quickly and more efficiently. And if that's not what your boss says, then totally ignore it.
Aren't you the boss of you?
I'm actually quite a little analytic. I love learning to be
Then you should keep doing it. Thanks all.
I'll invite people. And then everyone knows Mike, right? He's co-chair of our community.
I'm the about statistician for the division of